Hi, and welcome to another Memorial Hermann Facebook Live. I'm Evan Koch here on the campus of Memorial Hermann Greater Heights Hospital. Joining me today is Memorial Hermann Medical Group urologist, Dr. Adam Hollander. Dr. Hollander, thanks for being here.
Thank you for having me.
And we are talking about prostate cancer. It's Prostate Cancer Awareness Month. How common is prostate cancer?
Well, prostate cancer is the most common solid tumor in men. It affects about 1 in 7 men in their lifetimes, and therefore it's extremely common.
1 in 7, yes, very common. What are the signs and symptoms of prostate cancer?
The most common thing is for there to not be any signs and symptoms. Most men in 2018 are picked up via screening. If there are signs and symptoms, they can be similar to those of enlarged prostate, problems urinating, having to go to the bathroom frequently, having to wake up at night to go to the bathroom, but that's less common. Most commonly, there are no signs and symptoms.
Wow, so there's no signs and symptoms, relatively common. Who is at risk of prostate cancer?
The risk for prostate cancer goes up as men age. So it is a linear progression from age 30 on up. So it's most common in men in their 70s and 80s. And we typically begin screening around age 55.
Okay, so we begin screening around age 55. What does the screening entail?
The screening's pretty simple. It's a normal history and physical exam with the patient, checking the size of the prostate, checking to see if there's any bumps or nodules on the prostate. The second part of the screening is a blood test called PSA, and that measures the activity level of the prostate. If that number is elevated, then that could mean that there is some risk for prostate cancer.
Okay, so it sounds like a relatively simple screening test. Do people need to go to a urologist? Can they go to their general physician? Who do they go to?
Either one. I routinely do prostate cancer screening for my patients that are in that age range. Lots of primary care doctors do prostate cancer screening for their patients. So whatever the patient's most comfortable with. Most patients will have a primary care doctor when they're in their 50s, so that's a good point of contact for initiating the screening process. But urologists routinely see those patients as well.
Okay, so let's talk worst case scenario that there's a screening done and the results come back positive for cancer. How is the person diagnosed and what steps do they take next?
So the screening itself cannot diagnose the cancer. The screening itself tells me that there is some risk for prostate cancer. Unfortunately, the PSA test is not perfect. There are other things that can make that number go high. And so if we get a patient that has a high PSA and we do think that there's some risk for cancer, the next step would be a biopsy of the prostate, which is a relatively simple procedure that a urologist would perform in his or her office.
Okay, and so they go through the biopsy, and then those are the steps that are needed to be taken to get confirm a diagnosis. Where do they go after that?
Well, normally what happens is they would then meet with their urologist who did the biopsy to discuss the results. Prostate cancer comes in a wide variety of flavors. There are some types of prostate cancer that will not impact a man's life, that can just be observed safely without having any sort of treatment. On the other hand, there are other types of prostate cancer that can be very aggressive and can certainly be life-shortening. And so it's up to the urologist to have that discussion with their patient about what the biopsy showed, if there was cancer, how much cancer there was, and what the aggressiveness of the cancer is in order to be able to make an informed decision about whether treatment should be pursued, and if so, which treatment it should be.
So I want to go back a little bit and talk about family history as a risk factor. What are we looking at there as far as, is it your father, is it your brother, is it a cousin, is it an uncle, or is it anyone in the family?
It's anyone in the family, but the risk is greatest for first-degree relatives, so parents, brothers, that kind of thing. I always ask my patients if anyone in their family had prostate cancer, especially if it was diagnosed at an early age, that would make me want to start screening those patients earlier. So the American Urologic Association recommendations for screening say that in the general population, you start at age 55, but if there is any family history or other risk factors, the other big risk factor being African American race, then you start at age 50. or 5 years before the closest family member was diagnosed. So if you had a family member who was diagnosed in their 40s, you would want to start at that age.
Got it. So in terms of prostate cancer, what is the role of a urologist and an oncologist as if that does develop into prostate cancer?
So that depends a lot on the stage of the cancer when it's diagnosed. There is a big difference between cancer that is what we call clinically localized, just inside the prostate, versus cancer that has spread to either the lymph nodes or to the rest of the body. In the former case, the clinically localized prostate cancer, that is usually the treatment is usually spearheaded by the urologist with a combination with radiation oncology sometimes. If the cancer has spread, then a lot of times those patients will get referred to an oncologist for treatment.
All right, so earlier you mentioned that there's a wide variety of prostate cancers. Is there a wide variety of treatment options?
There's a very wide variety of treatment options. Prostate cancer is very complicated, and there are several good treatment options. The good thing is that in clinically localized prostate cancer, if caught early, that is a very potentially curable disease. And so the main options for that would be surgery to remove the prostate or some sort of radiation to treat the prostate that way. There are emerging experimental treatments for prostate cancer that I think will be very useful in the coming years, but in my opinion don't have the sort of data that I like to throw behind my decision making to be able to offer them right now.
You mentioned surgery and radiation. What about chemotherapy?
Chemotherapy is more often used in men that have prostate cancer that's spread. It normally is not offered in clinically localized prostate cancer.
So I'm going to cheat here, folks. I'm going to look down to pronounce this. What is a robotic-assisted laparoscopic radical prostatectomy?
Well done. So the surgery to remove a prostate can take one of two forms. It can be done robotically, which is, you just gave the long name for that, or it can be done via open surgery. Most urologists who are being trained nowadays will do that surgery robotically. The advantage to robotic surgery is that it's a minimally invasive approach to taking the surgery, taking the prostate out. It's still essentially the same surgery as has been done for years in urology, but it's done via smaller incisions and with less blood loss and usually a shorter hospital stay. So the patients do tend to recover a little bit more quickly from that. There is some thought, although the data is still emerging, that the side effects and risks of surgery can be minimized with a robotic approach. So that's what I offer my patients when they go down the surgical route. And that is sort of where modern urology is arriving at this point.
So I'm going to skip around a little bit here. We're talking about prostate cancer. Are there other benefits beyond prostate cancer detection to getting your prostate exam?
There are. Even more common than prostate cancer is enlarged prostate. Just because a patient's prostate is enlarged does not mean they have prostate cancer. And just because it's not enlarged doesn't mean they don't have prostate cancer. But the prostate does grow every year that a man is alive. And as it gets larger, it can start to obstruct the flow of urine. And so men who get into their 50s and 60s and 70s will notice that their urinary stream may decrease, that they may have to get up more often to go to the bathroom, that they have a hard time emptying their bladder. And those are all easily treated with medications that are commonly given for that problem. So that is a very common thing that we see in men in their 60s and 70s.
So it sounds like an enlarged prostate, some of the signs and symptoms of an enlarged prostate could also be associated with a cancer, but not necessarily. So if you have an enlarged prostate, it doesn't absolutely mean you have cancer.
That's
and vice versa.
That's absolutely correct. And so that's why it's important to both do an exam of the prostate, but also the blood test. The blood test can go up with enlarged prostate, but in general, sort of the higher that blood test goes, the more risk there is for prostate cancer.
So, you know, for someone who's going through prostate cancer right now, what are ways that maybe their family or their support system can best support them?
Well, really, just as you would expect with any medical problem, having the support of your family is integral to going through any sort of major medical diagnosis. And so, encouraging people before diagnosis to see their doctor regularly, I think, is important. Staying as healthy as possible in other ways, things like controlling blood pressure, controlling diabetes, controlling obesity, those things can all impact your ability to make it through a major medical event. And so I think that those are the most important things. But really just being there to be supportive and lend an ear, I think is very useful.
So I want to recap a couple things what we've already talked about, which is prostate cancer is the most common solid cancer among men, 1 in 7 roughly.
Yes.
Okay. Having a prostate exam is not time consuming. It can be done by your urologist or a general practitioner.
Yes.
There are a vast array of prostate cancers and treatments. And having an enlarged prostate does not necessarily equate to having prostate cancer and vice versa.
Correct.
Is there anything else we need to be telling people about prostate cancer?
I think that is the gist of it. I think that it's very important that with screening, that early screening is very helpful because even if I think it's unusual that a 55-year-old would have prostate cancer, they can, but it's less common than people in their 70s. It's still very useful to have an array of screenings. In other words, to know what a patient's baseline is so that you can know if that number starts rising. The other useful aspect of that is that the earlier the cancer is detected, the better. If you can detect it while it is at a relatively non-aggressive stage, or certainly before it leaves the prostate, then this is a curable cancer, and with relatively minor interventions. On the other hand, if the cancer is not detected early, if it has spread, especially if it's spread to the bones or the liver or other things like that, then there's really not a whole lot that can be done about those type of cancers. And so there's a huge difference between clinically localized and metastatic prostate cancer.
Right. And that, I think that really highlights the importance of making sure you're maintaining your health yearly. You're going to the yearly checkups, your healthcare providers on top of your physical health, and you can really address any changes to that and catch those problems early.
I agree.
That's outstanding. Thank you so much for taking the time today. And thank you for joining us for another Memorial Hermann Facebook Live. If you do have any questions, please put them in the comments section. We will send them to Dr. Hollander and get you some answers. If you want to learn more about prostate cancer treatments and screening, please go to memorialhermann.org, and we'll see you next time. Thank you.
Thank you very much.